indulge in deeper into it, the executive committee or executive leadership will be meeting with them again. And, obviously, if there's those members that wanted to attend, that I believe is going to be October 31st, that we'll be meeting to go over some things that we've already asked, questions that were posed that day, to try to get down to the nuts and bolts, so that we are able to have them come back and share about the process. So we are very clear of how it works. And so that parents and family members, and most importantly, self-advocates, are able to use the system and get the necessary responses concerning their complaints. The other piece was that we were, looking forward to today. Of course, I wanted to make sure I gave an opportunity. Oh, the other thing is that with DDS is, I think it's tomorrow. And if you could, Catherine, I don't know if you have the link for that, but there will be a discussion, I believe it's tomorrow, the 24th, about the potential of the waiting list for DDA. So I'm sure that'll be a thorough conversation in need of the community's input and understanding of what that means or doesn't mean. And so hopefully within this meeting, we'll be sure to get that information in the chat so you can participate in that meeting as well. Craig, I am going to give you the microphone so that you can address some of the MPD, because when you get done, then I'll come back in to introduce our guests, okay? Or our partners.
Absolutely.
Mhm.
Thank you very much, Rhonda. Good to be
Uh-huh.
here today as a co-chair with Rhonda. And we have a great program today. One thing we wanted to give you updates on was from the last meeting. We went over comments we were going to be providing the police department regarding their standard operating procedures, their policy related to interactions with people with intellectual and developmental disabilities, as well as other disabilities too. And we provided a lot of feedback, very robust feedback, had a great meeting. All that information has been provided to the police department. And I'm also happy to, and so hopefully we'll see that implemented. We're going to continue to engage them on that on behalf of the Family Support Council. One other thing, though, we did get today, we received the learning objectives for an individuals with developmental intellectual disability training module, which we've been really urging them to do, training in the IDD area. So they're obviously going forward with that, which is great, and that's something we've advocated for. And they've sent us this training module. Just some of it's not that long, it's just a couple pages that summarizes what they'll be looking at, what their goals are. So that's something that I don't know if we have time to do it today. I don't want to delay this. Do we, Rhonda, maybe at the end? Do you think we might have just to show it? Do you think
we might be able to show it, but I think we'll see how it goes, because I know there's several questions that were submitted for Melissa and Anna, you know what I'm saying, prior to I mean within the registration and prior to that.
Understood. So what we'll do is we'll certainly as a leadership team provide comments. I'll email that. Catherine, is it okay if we share it with the members?
Yeah, so we'll send that out. We'll certainly send out that that draft to the voting members.
Okay, so and what we'd ask is for the voting members, email us back any comments you have.
But
Make sure to copy us, and we'll include it in our comments.
Yeah, I do think it would be a good idea to put in the chat though, Craig, what areas the community may want MPD to focus on during the training, at least to get some input from those that are here now. So we might pose that question in the chat. And so if anyone's hearing me, please in the chat, if there are objectives or areas that you want MPD to focus on for those with intellectual and developmental disabilities and the way in which they interact with them, and what are maybe skills or types of areas that the police need to be trained to adequately serve our community. As Craig said, we did give some feedback. There was some definite language, the words in which they describe our community and things like that, we had to make sure that that was respectfully done. So we are definitely looking through the information they're giving us with a fine-tooth comb to make sure that, we are making sure that our loved ones with disabilities are served as respected and valued citizens in the district by the MPD.
So I would just add to that. So you'll see when you look at this, and we'll send it to you all after the meeting. You'll see that it's pretty general. It's mostly just, their learning objectives. So they have like 3 main learning objectives and maybe 4 sub objectives for each one. What would be nice for us to do is maybe provide some sub objectives within those very general sub objectives of things that we would like them to maybe look at more specifically. I'll just give one example. They have one of the areas where they want to focus on training is identifying opportunities to support individuals with intellectual and developmental disabilities with community resources. So one subtopic would be identify community resources for individuals with IDD. And the second would be recognize when families of individuals with IDD can support and provide valuable information during police interactions. Now, that second one in particular is an opening for us to say, hey, you should be training the police to talk to the caregivers too, and not to isolate this individual or treat them in a way that makes them feel alone and in a situation where it could escalate. So, but it's a very general provision. So if anyone has ideas for how to be a little more specific, like maybe specific examples we'd like them to address, please provide that in response and we will put that in there. But I will tell you, this looks good. It looks like they're going to be having a comprehensive training. We just need to make it a little more detailed, I would say. And of course, we're going to want one of us to attend or a couple of us to attend to watch. And so we can provide further feedback. So we'll be recommending that as well, that we actually be able to attend and watch.
Yes, thank you, Craig. And I do see your comment, Ms. Rob, about mental health awareness with the police. So we will take into account your comment as we're going through this process. All right. One of the things, though, that we did find, you're welcome, is that the language that was used for those with intellectual and developmental disabilities and those with mental health disabilities, sometimes the way in which they were addressing them or the situation they may be in was crisis. And that was something that I think Craig and I have been working, I'm saying, to really understand, give them examples, right, of, what that may or may not be, because a situation for someone with IDD is not necessarily a crisis. It's just maybe the way in which they understand their community is different, right? Not that they're in a crisis situation and how they're interacting with their community. So thank you for looking into this. And like you said, we'll send it after the meeting for you all to look at, because we have a kind of quick turnaround for them to get information to them. So please, if you're not able or wouldn't have better access of calling, feel free to call me or Craig if you want to share those, some comments. We just want to make sure community is always involved. All right. At this time, I think we're down through the agenda. So we are ready. I think we'll start with Anna at this time. I know that you received several questions and I did invite several people, of course, but I do, since we have a little bit more time, Anna, if you could, I actually met someone Saturday at a Down syndrome library parent group, right? And someone didn't know about health services for children with special needs, right? And it's not the first time I've seen that, right? So just a general, overview of health services for children with special needs. And as you go into some of those questions, which I'm sure you'll be able to wrap that all in. Thank you so much, Anna. Anna Dunn is the president of Health Services for Children with Special Needs. I'm not sure if it's called now Children's National, but how that, even explain that, Anna.
Yes,
How that even works.
absolutely.
Thank you so much.
Absolutely. Well, first of all, thank you very much for inviting me to and HSCSN to share this information, and I very much appreciate the opportunity. There is another colleague of mine who joined, Claudia Jackson. So she is our Director of Enrollment and Outreach, and this topic is really, the kind of on a lot of people's minds. So if there are some questions that I won't be able to answer, she will step in. So essentially, we are a DC health plan that serves children and young adults up to the age 26 who are Medicaid eligible and have a disability. So there are two ways you can join HSCSN. You either have SSI diagnosis, you or the child, it's the child, right, that has SSI diagnosis and is SSI eligible, or has a condition that is SSI-like. So there is a disability. It may not necessarily qualify for SSI, but it impacts the child or the youth in a similar way. That in that situation, a provider, a doctor can write a referral for enrollment to HSCSN. And we train the PCPs, and DHCF train the PCPs most in the city to understand what the process is. And if there are any questions, they can reach out to us and to DHCF, and we can help provide the overview. So when the somebody is eligible for SSI, the enrollment into HSCSN is not immediate. It is a voluntary program. They are placed on a list, and then we conduct outreach to everybody who is on the list as potentially eligible for HSCSN. This is what Claudia's team does. So we go in the community, we knock at the doors with the addresses, we call the phone numbers that are available. This is the part that is very important. There are many, many instances when we can't reach families who are eligible for HSCSN because we receive incorrect information, the contact information, or information changes frequently. So the information that we have comes from the Medicaid eligibility file, and a lot of times that is outdated. So if you are in the community and if you are a partner, and if you know that somebody might be eligible, definitely feel free to initiate that conversation, because simply we may not have had an opportunity to reach them because we have an incorrect information, or they may not be on the list. So once we reach out to the family and share the information, educate them about HSCSN, they have to sign a consent saying, yes, I in fact would like to join to HSCSN, and understand that what services will be provided. And that kickstarts the enrollment process. Then we take that file, we send it over to the Department of Healthcare Finance that initiates actual enrollment into a health plan. So a couple things that are important to know about the program is that every enrollee has a care manager assigned, and that is really a feature why people choose to join HSCSN, and to be honest, why some people choose not to be enrolled in HSCSN, because not everybody wants to have a care manager calling them in and checking in. Some families are more self-sufficient. So we make sure during the outreach process that the potential enrollees really understand that, engagement with a care manager is ongoing, and kind of what comes with it, right? What our role is. Who can join the CASA program? So what I mentioned in the beginning is that we serve enrollees up to the age of 26. That said, if a child hasn't joined us by the age of 21, they can no longer join. So 21 to 26 are the enrollees that have been with us before the age 21. So it is our role for the ages between 21 and 26 really to support our enrollees who are already there, to transition them into adulthood, to connect them with adult systems of care, to facilitate applications to all appropriate waivers, etc. So when they at the age of 26, when they change the systems of care, or actually ideally they usually do between 21 and 26, so we can see them through that process, they are in a good place and there are no disruptions. We are, as Rhonda noted, we're a wholly owned subsidiary of Children's National. So what that means is that Children's National is a parent or organization of HSCSN. That said, as a health plan, we are totally independent and operate independently from Children's National. So Children's National is one of our providers, one of many providers that we have in our network. Currently, we have all hospitals with the exception of Sibley in our network, not only Children's National. Why the relationship with Children's National is important is because the majority of our enrollees, given the specialists that exist in Children's National, go for services there. So about 65% of our enrollees go there for primary care and about 90% go for specialty care. So what we where we're moving with our program is our care managers right now are actually on site in the clinics at Children's National, and we're also moving to, over the year to other providers as well to actually be where our enrollees are. So we cover all Medicaid eligible services, Medicaid covered services, and more. We also have value added benefits for our enrollees. And there are quite a few to mention, but I think one of them that I mentioned that is important perhaps for this community to hear is given the shortage of the PCA providers, home care providers in the pediatric space, we recognize that it is an issue and some families actually have been waiting for the PCA services for a while. So we started the benefit where we sponsor and support our caregivers to go through the training and get certified as a CNA, and then facilitate them getting employed with a home health agency so they can provide care to either others or, to somebody within their family unit. So that is just, at a glance who HSCSN is. We have been in this community serving our enrollees for 30 years now.
Who's on the light? Sorry about that. I guess you do have to hear me, right? One of the things that did happen, as it was noted in the chat, is that we would hear it's 21, it's 26. I mean, and in the pandemic, I think something did happen that I think there was a questionable moment there. But it is till 26 if you come in before 21. One of the things that was a question was, okay, I find a parent or a parent that has a child with a disability, they want HSCSN. Are they calling customer service and saying, I'm interested? How does that, where exactly does that happen? Is it send them to apply for Social Security first? Where does that really, how does that land?
Claudia, would you mind speaking about the process, please?
Absolutely. So, Rhonda, thank you for having us. So the question is, if a family is interested and they would like to enroll in CASA, they could initiate communication with us by calling our customer service, and we can check their eligibility then. And depending on their eligibility, we would advise them on what the process is.
Okay. So customer service is the place to first go, and then they'll get direction of where they should go from there. Is that correct?
Yes.
Okay, thank you.
And
Carmen.
I'd like to add too, prior to the outreach that we do from the list that we get from the district, we do send a letter to the address that we have received, letting them know that they're eligible for CASA. And that the letter includes the start of a consent that they can either mail back to us or provides instructions on how they can contact us.
I didn't realize that necessarily that you received a list from the city. Do you get anything from early stages or any of those? I'm just curious now that you've said that. I'm wondering if there's any collaboration to catch, and I think that may have happened to the person I met on Saturday, right? How is that collaboration, or is there one to catch?
No, the list would generate from the district.
Okay.
And they partner with ESA and the Social Security Administration to determine eligibility for CASA.
Okay, I was just curious if there was.
Yes, and I think, Rhonda, this is where the kind of the distinction is between the SSI like and SSI. So the enrollment is really, you need to have SSI. But if the child has a disability that is significant enough, then the next step, but they don't have SSI, then the next step will be to have the conversation with the pediatrician and initiate a referral. We do not adjudicate the referrals because we receive only those who are already eligible. So the district has a third-party contractor, Comagin, so the referrals from pediatrician go to a third party that reviews the doctor provided information, just like very similar to how SSI eligibility is determined. And if in fact it looks like that there is a significant impact that require the CASIP-like services, then they're added to, they're enrolled in the CASIP program.
And for everyone here, I'm going down the list as they know this, Anna does the list I gave her of questions. One of the things, once they're enrolled, right? Where are they getting the tutorial or information on what services are provided? Is that the care manager once they get assigned, or is it something different?
So I will start answering this question, and then I will pass it over to Tasha, who is joined as well. So Tasha is our director of care management, so she's definitely the person to know by the community. So with every enrollment, when the family consents, they're enrolled. So within the first month, within the first couple of weeks, we hold new enrollee orientation. So during that orientation, every enrollee has the option either to participate virtually or in person. They receive an enrollee handbook. They're provided with their opportunity to ask questions, provided with all of the contact information. And Tasha, I will pass over to you to talk about the assessment process and the assignment of the care manager, because that's the next step in the process. Every enrollee who comes to HSESN undergoes a comprehensive assessment so we can evaluate what their needs are and they can get the right care manager assigned. So I want Tasha to talk a little bit about what that process looks like.
Sure. Good afternoon, everyone. So yes, like Anna said, all of our care managers find out who their enrollees are and outreach those enrollees. Our goal is to outreach within 5 days of that new assignment to make sure the enrollee knows they have a care manager, they know how to contact them, and to arrange that initial comprehensive assessment. During that assessment, we're looking at, everything with the whole person, what situation, what type of environment they're in, who they live with, where they go to school, what providers, specialists that they have on board. So during that assessment, we're able to identify if there's any gaps in care, able to identify any concerns that the enrollee or families may have. If there's any social drivers of health that's really impacting them, we're able to identify that. Based on that assessment, we're able to let the enrollees and families know what services that we cover, what we have available to them, as well as resources that are available in the community, whether it's support groups or food resources, housing resources. we really try to look at the whole person and anything that's negatively impacting them, how we can assist them and connect them with resources. There's times that we do have multidisciplinary team meetings where we will bring those providers and specialists to the table to make sure that the enrollee understands, what their orders are or what their plans are, because as we know, a lot of families don't necessarily have that health literacy. So we try to be that liaison between the providers, the resources, and the families.
Thank you. I guess one of the things that I find as I'm working with families, it does take some learning curve. And, if you're a new parent, new diagnosis, new process, and don't really know where to go for
Right.
those therapies and services. And so that's why I ask about, that enrollment process, what work is being done, to really educate that new parent that doesn't know that, oh, my child has autism. I should be asking, doesn't know this, maybe for ABA, you know what I'm saying? And they don't realize that's something that is available, you know what I'm saying, to get, and just trying to make sure care managers or whoever that role is, has that, is able to explain that, which rolls into another question about care management. We still see that it's challenging. We're hearing comments of getting to the care managers. And I know there's now care supporters, which I think there might need some definition there. And there is a new app that I if someone could address those areas. Thank
Sure.
you.
Yes, we do have our care support specialists that are able to field calls. So if an enrollee or family call our main customer care line, they have an option to push for number 2 to go directly to the care management department. That is a person that is able to answer the phone throughout our business hours. And of course, we do have after-hour services as well. But these are unlicensed staff that are able to help with fielding questions, appointment scheduling, transportation, just any of those things that doesn't require an actual licensed care manager to do. Those staff are able to do that. So they're able to answer lots of questions, connect them with resources and all of that. So that's one way that we wanted to make sure that even if we have care managers that are actually out in the community seeing enrollees, which, obviously that's their main focus, is being out and about and seeing enrollees. So there are times that the enrollees and families would get their voicemail. So we wanted to make sure there was care management staff available all the time for those needs. So we've asked the care managers to have on their voicemail that if you need immediate assistance, please call the main line, press option 2 to get to the care support specialist, so that they're able to get their needs identified. And if it is something that only a care manager could do, but they're out in the field or in the community, then they're able to send it to leadership so that we're able to follow up on those items. We do have the app, it's called the Easy Connect Health app. And we're able to contact our enrollees and families like a direct messaging, so that they can contact us immediately for something. So if they're saying, hey, I don't have my ID card, or hey, I need help with transportation, that's something that will come directly to the care manager's computer, where the person doesn't have to make a phone call. It's like having a text message right there. One of the benefits too of the app is that it has resources for different health needs, care management needs, different resources that the families can get information like right at their fingertips. They can send us signed documents. We can send them documents. There's medication reminders, appointment reminders, and different things that's available in the app as well. But it is like another way for the person to be able to contact their care manager without having to wait, leave a message, and those type things.
I do have a question that I had received about transportation, right? And that is still a challenging area for families. And you mentioned the app being able to contact someone if I'm going to use the example of, they didn't pick them up, right? Or they're not on time, or there's just the struggle with even trying to book the transportation, right? So, even though I have some other questions with care management, but what is happening for those areas of struggles with transportation still?
Yeah, we have, just first of all, for the care management piece,
Mhm.
we advise our enrollees to call that main line because the care support specialists are very well educated with transportation and contacting Verida to escalate any issues. So if enrollees are saying, hey, I was supposed to be picked up at 9 and now it's 9:15, calling that direct number, the care support specialists are able to connect with Verida. They'll do warm handoffs, they'll be on the phone with those providers to see like what's going on and where they are. Anna, I can start.
I do have to say, the care supporter, it's been beneficial for me. I have
I'm glad to
definitely
hear
seen,
that.
but I don't think families know that exists. That's why I'm
Right.
bringing it. They don't know that that piece exists, and they were able to clear something up very fast for me compared to me trying to get a hold of the care manager. But I don't think parents are knowing that. I don't think voicemails are saying call the care supporter. You know what I'm saying?
Yeah.
And maybe the voicemail to the care manager needs to say, or call customer service for the
Make
care.
it a little bit beefed up. Yeah, we
Right.
just did the voicemail probably about 2 months ago because a lot of people were still leaving messages with the care manager. And
Mhm.
when we did do the centralization, we did send out a blast by letter, but that has been a while. So that's probably something that we could circle back to just to make that top of mind for everyone. Because yeah, as we started, of course, we were only getting a couple calls, but now we're getting, more than probably about 600 calls a month through that line versus them calling the care manager. So it hasn't improved, but yeah, we probably need to get that word out and keep bringing that up to people.
Yeah, I think there are just some, minor things that could be, taken care of. But the other part of it is a parent wants to be heard, right? So even if it's,
Absolutely.
that can you take this information, figure it out, so I'm not spending 3-4 hours in the day
Right.
trying to figure out what do I do, but I'm still standing here for transportation, or I'm still here, can't get the prescription filled. You know what I'm saying?
Absolutely.
Because it's saying the insurance won't take it, is not accepting it or whatever. All of those types of situations, would just help to de-escalate, hopefully,
Right.
some of the frustration, which leads to some of the issues of maybe the communication styles of some of the care managers of,
Mhm.
it is challenging right now for all of us, right?
Right.
With or without children with disabilities, we're all
Mhm.
experiencing a climate right now that is very stressful. That was the way it was for us before we are here
Right.
today, right? So
Right.
I do think one of the other questions or comments was, what is the training that might be happening for care managers, maybe in the area of, mental health, knowing how to
Mhm.
maybe address those needs in the way that
Right.
if it's a referral, or even knowing just how to deal with, hearing a parent say, I'm overwhelmed. You know what I'm saying?
Right.
What does that look like? Because they are looking for that help. And if they're coming to you, obviously,
Mhm.
it's not always roses. There's
Right.
something going on, and the
Absolutely.
need is there. So what is being done to maybe make the care management training more robust to handle those areas? And as well as I'm assuming that the care managers need the support themselves,
Right.
to handle the load that they have of
Right.
the many members that each one is caring for or supporting.
Right.
Mhm.
Yeah, we recently have a new position, the manager of clinical excellence, and her whole focus is on onboarding our new staff as well as training our current staff. So really looking at really a needs assessment. Where do we feel like our care managers aren't necessarily as confident and as comfortable as they should be? We took some of those ideas and needs to our chief medical officer, as well as our chief psychiatric medical officer and our behavioral health specialist director, so that we could get more education on specific diagnoses, on the ABA services that are out there. We've worked a lot on de-escalating for people that do, like by the time they've gotten to the care support specialist, a lot of times they've tried a lot of things and they're kind of angry So being able to de-escalate so that we can really show the person, yes, we understand and we're here to help you, and how can we, move forward and make it better. So we've really looked at those gaps and listened to our care managers that say, hey, I'm getting questions about this all the time. I need more information about it. Also coming up with a resource vessel where someone can type in something like ABA services and we can see, oh, these are our in-network providers. Having our care support specialists call those providers to see who has openings, who's filled, who can only see someone that's, between the ages of 5 and 12 versus, people that only see the little ones. So really trying to give our care managers more tools so that they can be a better resource to our families and enrollees. And then one of the things that we looked at from our employee survey was, people feeling like we care about their health and well-being. How are we helping them deal with people that are, like you said, they are calling us in a crisis moment, or they're dealing with a very sick child. And sometimes our care managers have been with this family for a very long time, and now they're losing their child. How do we help to make sure that we are showing our care managers that we care about their health and well-being, not just them, doing the job. So those are all things that we are really working on, really focusing on, and hopefully it helps our staff feel more equipped and confident as they're talking to the families.
Yes, I think we probably cannot say it enough, and I can understand by the time you get to where you are, that parent is very frustrated and knowing
Right.
how to address those issues. I guess the other part of it is too, is that because a parent is very frustrated, there are some changes that have happened to what respite looks like, right?
Mhm.
Respite has now changed, especially for skilled, if you're getting skilled nursing, really there isn't any, if I'm correct. Because and I'll give the example though from a personal perspective, if if a if a child is in need of medication, also tube feeding, all of those things, those are skilled nursing. So if that is in an interval of 2 and 3 hours, even if a CNA comes in, where's the respite, right? Where does that work? Because you still need the mother or the father or whoever that is. And in this case, it would be, a parent there to be able to meet those needs. So there's not a true respite that happens. So my question is to that question, plus giving an overview of what respite care looks like now. You know what I'm saying? Now that things have changed and where they're landed, or maybe what they might look like for the future as well.
Right.
Mhm.
I know for, like you said, respite for a skilled service, such as given medications and all of those things, the value added benefit was discontinued. The respite really is more focused right now on the personal care and the activities of daily living and being able to give someone that break. And there is definitely, and Anna may be able to talk about this a little bit more. I think that the caregiver relief for the skilled care was something that our agencies that are in our network and the agencies that are in the district really weren't able to fulfill for us. So when we had that request from a parent, there generally was not the registered nurses or LPNs that were able to fulfill that need. So, consistently, we were really working with families where we could get the assistance and trying to find ways to really entice and motivate those agencies for the help. But the nurses just really weren't there. Anna, is there any more that you could say about that?
Yes, there are a couple things. One is there is a shortage of providers in pediatric space. Our enrollees 21 and over, we don't have any challenges with staffing the cases with, both for home health services, PCA, or skilled nursing or respite. anything under 21, there is a shortage. So because the providers are so short on staff in even available cases, the respite is even more challenging to staff, especially the, the short shifts. I think another challenge that we also see is that in order to staff the case for the respite, there still needs to be an available adult present. And we see that our families were challenged to identify any available adult because that, essentially kind of defeats for them the purpose of respite. If the adult is available, then they could potentially, take care of the enrollee, right? And it was really a challenge. So both from, both those sides, we did see low utilization as well. So kind of caregivers just gave up on trying to request the service because the likelihood that it will be fulfilled on the skilled nursing side is really low. I don't know, Melissa, like I hate putting you on the spot, but I don't know if, there is something that you could share kind of, through the district lens about the shortage of the providers and the home health space and what DHCF is doing in that area.
Thank you for helping me make that transition. As I put in the chat, that will be transitioning to Melissa Bird, who is the Medicaid director. So we are grateful for her to be here as well. So Melissa, we'll let you take the microphone now.
Hey, thanks so much, Rhonda, and good afternoon, everyone. Thanks so much for having me on today. To Anna's question, we were just talking with the Long-Term Care Coalition yesterday about some of these issues. So there's no quick answer or resolution, which you all know as well, just from your use of the services. But from the agency perspective, we have a longer term effort underway to really think about how we pay for services specific for home health. And is there a way that we can do it that will allow flexibility in the different kinds of discrete providers, if you will? So maybe you need a PCA for a while, maybe you need a skilled nurse for a while, maybe you need something more or less, and how we can do it where it works well for the provider in terms of recruiting individuals, but then also here in our space is making sure that folks are working at the top of their license or their certification, which means then it has a tendency to kind of make sure folks are doing what they're best equipped to do. And then you can bring in other workers as well. So that's not a great answer. I know, like, again, it doesn't resolve the issue, but that's one of the ways that we can try to support some changes. It really is through that payment. I know also we have supported through some funding to DOH, the Department of Health, money to provide scholarships for individuals who are interested in becoming personal care aides. There's a licensure or certification process that you have to go through that comes with a cost. I feel like it's about $1,500. And so trying to support and provide funding there so folks aren't so that they can afford to actually go through the process and to join the field. So that's a really high level overview, and willing to take more questions on that. And then Rhonda, I've got a PowerPoint presentation. Oh, look at Catherine. So I can walk through this. I'll try to address any questions, whether it's direct to what you're gonna see on the screen or not. But I wanted to talk to folks today about some of the changes to Medicaid that's gonna be coming up over the next year or so. We all know Medicaid has been in the news, like just almost every day, it feels like, this calendar year. And some of this stuff can sound, I think, confusing. And yes, Carol will send out the PowerPoint for sure, and to understand what is happening and when. So first, Catherine, is it possible to go in presentation mode so it's a little bit bigger for this middle-aged lady's eyeballs?
Sure. Let me switch that up. I thought I was in there, but it looks like my screen's jumped it to a different one. So let me fix that.
Can't be too close, can't be too far while I'm in that special place until I get my progressives. And I did see a comment. I just wanted to acknowledge one of the comments about the appointments at Social Security. There's a real delay and that. And I want to say I've had some experience with this with a family already. And I just, after seeing this comment in the chat, have followed up with my team. And we will follow up with the support council to get clarity. What's most likely is that your child will still meet eligibility, but we will need to have an actual Medicaid application. If your child is enrolled in Medicaid now because they have SSI, that's an automatic enrollment. And we likely don't have an application on file because the information comes to us from Social Security. So for us to be, what that means, if we don't have an application on file, which we shouldn't if it's coming straight from Social Security, so I don't want to suggest anything wrong is happening, but for us to maintain your child's eligibility, we have to have certain information, and that's information we may not have because we've always gotten their eligibility from Social Security. So a couple things. If you find yourself in this predicament, feel free to reach out to me and I'll make sure we get you connected with the next steps. You can always call our healthcare ombudsman's office. If you're already connected with HSCSN, they will help you as well. And what we'll do is once we have the eligibility application, we can process it. We'll make sure if you're like with HSCSN that you maintain that enrollment with HSCSN. The biggest thing is reach out as soon as possible if you are coming up on that restart time frame. As soon as possible, because that way we can just do our best to make sure there's no lapse in coverage, which I know is probably one of the worst things that can happen in terms of making sure you maintain all your caregivers and everyone else. So I just wanted to get that out real quick.
Thank you.
Okay, you're welcome. If we go to the next slide, please. So I think we have I think the time allotted is maybe half an hour. So I'll do my best to cover stuff, not go too fast. But I also want to make sure, even though it says Q&A at the end, please feel free to put a question in the chat or to ask one as I'm going along. And we can make it as much of a conversation as folks want. I'm going to just do a really high level about DC Medicaid, and then I'll go into the upcoming Medicaid eligibility changes that are happening either because of local reasons or federal policy changes as well. So we go to the next slide. So DC Medicaid covers about 40% of district residents. This is broken out, and just so you know, enrollment, this slide was created earlier this year. Enrollment's always changing, so this is just representative of a point in time. But right now, it's still about 40% of district residents. You see about 42% of residents have Medicaid or CHIP. In DC, we typically just say Medicaid, and that's inclusive of both Medicaid and CHIP. CHIP is the Children's Health Insurance Program, because we just expanded our Medicaid program and we don't treat Medicaid and CHIP kids differently. They're just Medicaid for us. Next slide, please. Sorry for the little dings. I wanted to touch on financing a little bit and what I think possibly are the questions. So first, Medicaid is a federal and state, or in our case, a district program. So it's jointly run. And the federal government shares in financing as well as oversight. They set some standard policy, they set mandatory benefits, and approve all the things that are optional as well. The federal share is called Federal Financial Participation, or FFP. And the amount of FFP for each state is calculated using something called the FMAP. But of course, the DC is different. And you may have heard about this at the, it was probably like springish of this year when there were some questions about DC's FMAP. The District of Columbia's FMAP is statutorily set at 70% for most programs, which means that the federal government pays for 70 cents out of every dollar we spend on direct care. There's other federal percentages, like our administrative costs get something. The CHIP program, like I mentioned, actually has a higher FMAP, but the one that is kind of the standard FMAP, you'd say, is 70-30. So again, the feds pay 70% and the district pays 30%. And states have to use local dollars to match or to get that federal funding. So typically this comes through the allocation of local revenue. If you follow the budget formulation process, you'll see, you know, where all of our local dollars come from. I wanted to highlight provider taxes because provider taxes have been one of the key things that have been talked about over the past year. On the federal side, really through all the congressional debate about Medicaid earlier this year for the One Big Beautiful Bill Act. States can use provider taxes, so tax a provider like a hospital, nursing facilities, intermediate care facilities for individuals with developmental disabilities, like I said, nursing facilities, and bring that money and may use that money for local match or for other reasons. And the One Big Beautiful Bill puts some new rules on provider taxes, specifically those on hospitals. And so you may have seen a lot of headlines about how states are going to have financial issues because of these changes. And I just want to say in the district, we use provider taxes as well. But pretty much all of our provider taxes go and support the rates for those providers. What states have an option to do with the provider tax, let's say, I got to keep it simple. Let's say we get $100 from a provider for a tax, and maybe we use $10 to support that provider's rate, but then we use the other $90 just to be our local match to help us get the federal funds down. So that means we're becoming more reliant on that provider tax to have the basic funding that we need to run our program. And that is really not how the district is set up. Most of our provider tax money goes right back into that rate, and then we have those local dollars appropriated to support our program. So while there are significant changes to how provider taxes work in Medicaid going forward, its impact to the district is not going to be as impactful as some other states that heavily rely on provider taxes to fund all their local share or a good portion of their local share. So I hope that makes some sense. I just want to put that out there because there is a lot when I know, at least when I look nationally, about these impacts. And again, they're true, but every state program is a little bit different. And so these nuances can be really important. So I just want to say again, you know, while we have provider taxes in the district, again, most of those provider taxes go back into rates specific to those providers, and we're not pulling on that money as our local share for what we need to run majority of our program. Next slide. And that's all I'll say on financing right now, but I'll take any questions on things. I wanted to just give a little snapshot on kind of how the spending does look in the district. And so really at a glance, you will see based on this pie chart in front of you that most of our spending is for child behavioral health and long-term care services. And you see kind of the green piece of the pie is what we have spent on kids in the past, so about $528 million. You see the long-term services and supports. This is just for adults. Kids services are in that green piece of the pie, over $1 billion. So really on those three areas is where you see most of our spending. And if we go to the next slide, in Medicaid, some services are mandatory and some services are optional, and states can choose whether they provide optional benefits. And when you look at mandatory versus optional, you will see that it's about a 50-50 split, that about half of our spending for optional benefits for adults, that is about half of Medicaid spending. And so that's the large slice of the pie on the left side. And I highlight this because what is considered optional, you might not think is optional, like prescription drugs or dental services or mental health and substance use services or home and community-based services. And so I think it's really important. It's been important, I can say, throughout this year, as there's been a lot of debate on the national level to really tease these things out and show when we say mandatory or optional, what kind of services we're really talking about for folks. And then for kids, you see that smaller slice of the pie, almost a little over $500 million. And again, that would be inclusive of like what we pay HSCSN and all other services for kids. Next slide, please. So with that, I'm going to move in and talk about some of the changes. There are a lot of things happening on the local level that is a reality that we're having to face. And then we have federal federal changes through the One Big Beautiful Act, which I'll refer to as OBA or OB3, that also have significant changes to the Medicaid program. And so locally, if you've been tracking things, you know that our revenues are down across the district. As we went through our budget process this year, we, continue to see healthcare costs increase. I've never really seen them decrease in my career. And then we also see an increased enrollment. And all these three things have come together to really challenge some of our program sustainability. The One Big Beautiful Bill Act, or OB3, has some significant changes for the Medicaid program, for all state Medicaid programs, including work requirements for some adults in Medicaid, a more frequent eligibility check for some adults enrolled in Medicaid, and a lot more. So if we go to the next slide. I'm going to talk for the next couple of minutes about the local changes that are coming up. Thanks. Well, actually, I'm going to do a quick overview of all the changes. So there's a lot going on in Medicaid. There's also a lot going on in a program called our Healthcare Alliance program. And it's all happening like from now through January 1, 2027. So I'm trying to make it as clear as possible that what's happening and when. So on January 1st, on 2026, we're going to have some income eligibility changes for some adults in the Medicaid program. And I'll go into some details in just a moment. I'll go into some detail for most of these. And then we move forward to October 1st, 2026. So just a little under a year from now. The one OB3 makes some changes to the definition of qualified immigrants. And what this is going to result in is that some people with legal immigration statuses will no longer be Medicaid eligible. And then finally, in terms of just thinking about the next year, on January 1st, 2027, not 26, 27, is when some adults will have to fulfill work requirements, and some adults will have to recertify their eligibility every 6 months to maintain Medicaid enrollment. There'll also be a change to retroactive Medicaid coverage. If you're familiar with that, when you come into Medicaid on data application, if you've had some out-of-pocket costs up to 3 months prior to your application, you can request retroactive coverage and we can support those costs. Next slide, please. Okay, so the changes that are happening local. And I'm not going to go through every word that's on this slide, but I did want to provide folks the chart on the right so you could really see kind of what the impact is and who will be affected. So effective January 1st, 2026, our income eligibility, I'm going to say more Medicaid-like, and I'll try to make it sound like what would make sense, reduces from about anywhere from 215 or 220% of the federal poverty level down to 138%. What that really means for a single person, like a single adult with no kids, if they're making $1,800 a month or more, they likely will not be eligible for Medicaid if their eligibility is based solely on income. And when we talk about these adults, they are defined for Medicaid purposes in two categories: parent caretakers and childless adults. There's also some adults or parents that may have both Medicare and Medicaid, and it may get full benefits from Medicare and Medicaid. If they are above this eligibility level, they will still have their full Medicare benefit. Instead of getting all the Medicaid benefit as well, Medicaid will only pay for their Medicare premiums and cost sharing. So a bit of a change. One thing that I think is really important to make sure that folks understand is that children can be eligible for Medicaid even when their parents are not. So if you have a friend, family member, neighbor who today has Medicaid and is looking like they may not have Medicaid come January 1st, and they have children, there's a really most likely that child is still going to be Medicaid eligible because we're making no changes to children's Medicaid eligibility. Next slide, please. And as this change is happening for Medicaid eligibility, there's a new coverage option that is becoming available in the district, and it's called the Healthy DC Plan. Most adults that are eligible for Medicaid today that won't be starting January 1st will have this option through the health benefits exchange. We estimate about 90% of the adults. And the Healthy DC plan will be administered by the DC Health Benefits Exchange, or HBX. It will be at no cost, no co-pays, no premiums, no cost sharing. And many of the services that are currently covered by Medicaid are included. There are some differences. There's no non-emergency transportation, no dental and vision, and some other supports as well. And what we're trying to do, our hope is to make it seamless for those residents who are impacted, is that they will be automatically enrolled into the Healthy DC plan without having to do anything themselves. And that's work that is going on between the Department of Healthcare Finance and the Health Benefits Exchange right now. And then there's a link here if you want to find out more information about Healthy DC plan, you can do so. Next slide, please. And I think on the next slide I have, one thing, just because I think we're just an amazing community here in DC, and I know you all talk to other folks too. Again, if you know that someone that might be impacted by these adult eligibility changes, like I said, the transition should, our intent, our goal is to make it as seamless as possible. But folks will also have to have a DC HealthLink account. And for those who are already in District Direct, which is our Medicaid system for eligibility, they're going to be able to use their District Direct login and password for their DC HealthLink as well. So they won't have to start from scratch. And so there's some more information on this slide, just so folks know where to go or who to call with any questions related to that. And the next slide. You will find information and resources on the DHCF website. Once you get the slides, you should be able to link to these easily. We have a Medicaid director letter, which is just a way to share our policy with the public that talks about these changes. And then a frequently asked questions document that's live, and we'll update as we get more questions and have answers to share with folks. We have recurring meetings for partners and residents every other Wednesday, the next one being November 5th at 2:30 in the afternoon. We go over all the updates related to the changes that are happening to our healthcare programs right now. And then we are holding a monthly resident meeting. The next one is actually this Friday at 6:30. And this is a space to really just try to make it available for our neighbors to ask any questions that they might have, get connected with us if they have specific information about their own case, and to help people navigate through these changes. Next slide. Okay, and then looking ahead, so most of the changes that are happening because of federal legislative changes really start into 2026 and then go into 2027. So I mentioned this earlier, that some folks with legal immigration statuses may lose Medicaid coverage, and this will happen on October 1st, 2026. And then as we go into January 1st, 2027, we have the new work requirements and recertification every 6 months for some folks. Next slide. I'm going to go into some detail on work requirements because I know there are a lot of questions. I will tell you there are not a lot of answers just yet. When the legislation passed in July, I think there's maybe 3 or 4 pages on work requirements, and that's the guidance that we have at this point, supporting the work that we're doing on this as well. But with the so I included the section of OB3 for folks who like to read legislative text. It's not my favorite thing to do, but it is nice to be able to go back to the source. So that's in there just for your reference. But the requirement is 80 hours of community engagement or work per month, and it can be met through different ways. It can be met through work, community service, participating in a work program, or being enrolled in an education program, like at least part-time. The eligible population, those who this requirement applies to, are those able-bodied adults aged 19 to 64 who do not have dependents. And there are several exceptions that might apply to residents. So if we go to the next slide, I'll cover some of those exceptions. And there's a lot of them, but I figured this might be something that was of interest to you all here. So I wanted to go through all of them, and I'll highlight them. So folks where the work requirement will not apply to them. If you are pregnant, if you are enrolled in or entitled to Medicare Part A coverage or enrolled in Medicare Part B coverage. If you're a foster youth or former foster youth under 26, this does not apply to you. If you're a veteran with rated disabilities, this doesn't apply to you. If you're an individual considered medically frail, and this includes but is not limited to, you may be blind or have a disability, have a chronic substance use disorder, SUD, or disabling mental disorder. You may have a physical or intellectual developmental disability that significantly impairs one or more activities of daily living, and or you may have serious and complex medical condition, excuse me. Also, if you are an individual participating in a substance use or alcohol use disorder treatment program, you're accepted. If you're compliant with SNAP or TANF, so SNAP is like food stamps, and TANF work requirements, then you will be deemed compliant with the Medicaid work requirements. If you're the parent or a caregiver of a dependent child that's 13 or younger, or a parent caregiver of an individual with a disability, you are accepted. And then if you've just been released from incarceration within the past 90 days, you are accepted as well. Next slide, please. So I've talked about a lot of stuff. These changes are significant. The ones specific to like OB3 really do the work requirements, particularly really for us, span policy, operations, and outreach. The things that DHCF is focused on in the next few months, really between now, well, it's really the next few months. There is some, it's unclear yet if the federal government is going to define medically frail or if states will have the ability to define medically frail. So we're going to start working on that and determine, we're going to be prepared if the feds don't say, here's your definition. You can also attest to certain things, like attest to your community engagement and so forth. So deciding whether that's going to be an option for us. We have an integrated eligibility system here in the district. So what that means, that's really great, but it also means any change we're making to Medicaid, we also have to think about how that impacts SNAP or TANF as well from a systems perspective. And most importantly, we've got to make sure that impacted residents know what is changing and when. Our goal here is really to be customer forward as we're thinking about work requirements and minimize the actions needed for someone to verify their work, school, or volunteering. My biggest kind of takeaway for folks right now, like no action for work requirements from individuals is needed now. But you will hear more from DHCF as we move into calendar year 2026 and start to have some more defined understanding of the work requirements and how they will be implemented. And the next slide, I think that's it. Yep. All the contact information, our website. If you want to get regular updates on the changes to Medicaid or join or get information on our biweekly stakeholder meetings or our resident town halls, you can email us at medicaid.renewal@dc.gov. And at any time, feel free to email me or call me. That's my cell phone number, or text if that works better. And I'll do my best to respond or get you to the person who has the answer for you. That's it, Rhonda. Happy to take any questions or comments, concerns.
Yes, thank you, Melissa. I know you were trying to fly through that and you made it. One of the, I did not receive the questions that were in the registration, so maybe Catherine has
There were
those.
not, yeah, there were not any. There was one that was a kind of a global question about changes or cuts, but
Okay.
not specific to one particular benefit type.
Yeah, one question that I think it kind of rolls into itself, but it's kind of similar to what was discussed with Anna when we were talking about skilled nursing, right? And if it comes to the point that a parent, if there's this shortage of nursing and all of this, therefore the parent is now stepping in, right, to do a lot of that supporting. So if that is the case, then as it refers to the Medicaid piece, right, for that parent, am I understanding, Melissa, the definition for who would be covered in Medicaid, if a parent now has to stop, you know what I'm saying, working to take care of their child because there's this shortage, are they covered in the description that you had of exception, that you have a child with a disability, a caregiver?
Yep.
Are you catching where I am? If is there supports there?
Like,
Yep. My read
I
right
know.
now of the legislation is that if you are a parent with a child with a disability, you are accepted from the work requirement. So that's how I read it.
Okay.
And if no other definition comes from the federal government, then that's how we read it. And I haven't heard, I don't think I've heard of any of my colleagues like in other states interpret that differently either. But I think that's the biggest point.
Okay, and then one other question across that lane of the respite for those with who their loved one is receiving skilled nursing. Is there some leadway in the sense of that if there's been some kinks of having nursing services if the child travels, right? Or the person travels, right? And they get home nursing, but let's say they go on a trip, right? Even if it is to Virginia, Maryland, maybe it's, California, whatever that is there a possibility of making sure that nursing services goes with that person, especially since they're not able to, or the parent isn't, you know what I'm saying, able to get respite, right? Is that another way to get coverage, right?
Yep.
If we have the nursing. Mhm.
Rhonda,
Mhm.
I have to think through that. The part that gives me the most pause is payment for the provider to travel. So
Mhm.
not the actual payment for the service rendered, right? But
Mhm.
it's more about how the provider, just to be really like straightforward, like
Mhm.
who's paying for their hotel, who's paying for the airline ticket, that kind of stuff. That's the piece that makes me pause, because I would presume, when people go out of state and they have services, and I'm thinking more of like when you're displaced from your home, let's say in district, we can still, cover those services. Travel, I don't know what the policy says or what the detail is, but I will follow up on that, Rhonda. And
Yeah,
Anna, if
just
you
trying to
happen to know, not to put you on the spot, but if you happen to know, feel free to speak up. But I'll follow up on that.
Yeah, the thing is, you don't want the family stuck in the house, right? I mean, let's just be
Yep.
real. You don't want the
Yep.
person with the disability stuck in their home in nursing, even if it is out in the community, because that's a whole nother thing. Because if you have skilled nursing, there's a nurse that handles skilled nursing, but you still need a PCA or someone else to help them engage their community, right? So that whole situation needs to be thought out a little bit more, because finding a way where there is some way to live, to play, to work in your community, even if you have multiple support needs. And the person that's supporting them exclusively in with the help of nursing needs that respite as well. I see that Craig has his hand up. Thank you, Melissa. I'm gonna go with Craig since he has his hand up. If there's other questions, please put them in the chat or raise your hand, please. Thank you.
Thank you, Rhonda.
Uh-huh.
Melissa, thank you so much for the wonderful presentation today. It was very helpful. Relieving in some ways, in other ways concerning, of course. But so just as a bottom line, since we're the constituency board for people with intellectual and developmental disabilities. So, and I think you just said this, but I just want to make sure. So, if we have someone who is receiving Medicaid either through HSCSN or through DDS, and maybe on the IDD waiver, but so they're receiving they're receiving those services, they're receiving those supports. This doesn't really change anything for them.
Correct. Like if you are eligible based on SSI, and particularly if you're in a waiver program, the work requirement does not apply to you.
And I guess one question I had though was, over time, do you see this as reducing the amount of benefits available for that population?
Well, I certainly can't predict. That's in part why I talked about some of the provider tax financing at the front, because I do think, I got a lot of questions during the kind of when reconciliation or the OB3 was still in discussion about that. And to be honest, like I was kind of scratching my head as well. I wasn't seeing kind of the direct connection. But it really does, I think, dig into how your state financing for your program works. So I think by virtue of that, I mean, there's always an impact on everything. We have, I think, quite frankly, you know, the thing I'm more focused on right now is what is our current district revenue outlook. And I think that's more important for us at this point in time than some of those changes there. So for us on this one for DC, and what I mean by that, there will be impacts, the cost that we will have to allocate because we have to spend money to set up the work requirements and be able to do all those things. But the change in like provider tax stuff does not impact us too much, and how we finance isn't impacted too much. So just, I think it's still going to be a challenging time for Medicaid just because of normal costs.
Understood.
So I can't say yes or no, but the kind of, if you're really going back to kind of, you know, spring to summer and the kind of different headlines and discussions that you saw, I right now, you know, feel I'm not concerned that, you know, programs are going to be obliterated at this point in time.
Thank you. And then I wanted you to know I did take you up on your invitation and sent you an email about my own daughter. So thank you. Thank you for offering to do that. And
Okay,
really
no problem.
great to
Thanks.
have you here today.
Oh, well, I'm glad to be here. I appreciate you guys and your input and everything. It's helpful to us.
Great. I know you all have other things to be doing to make sure that we can maintain some of these services and support. So we appreciate you taking the time today. I had another question, but before I do that, I want to make sure there wasn't anyone from the community because I have questions, but I wanted to make sure that there was not other questions that that others had that are here today. If so, if you don't want to speak, then please feel free to put it in the chat. While we're waiting for that, I have a question. One of the things, and just give me clarity if I misunderstood what you said, Melissa. Did you say if a person earns $1,800 a month, that they will not, or that's the cap of if they get? Okay, could you explain that a little bit more for me?
If you're pretty much at around 1,800 or less, you're
Mhm.
per month, you're likely going to be eligible for Medicaid. If you're over 1,800 as an adult, you are in an adult that's coming into the program by virtue of only their income eligibility, not that you might have a disability or you're over 65, something like that. If it's over $1,800, you will likely not be eligible. So today, without changes, and I'm looking at my chart here, if you were a single person, no one else in your household, so just one, our eligibility, you could be making up to about $2,800 a month and still be eligible for Medicaid. And then that will change to 1,800 January 1st.
Yeah.
But the option,
Go ahead.
it is a change, right? But that's where I feel like it's just really great that we have the new Healthy DC plan that's going to be live and be available for most folks that fall in that category that's going to be impacted by our changes. And again, the Healthy DC plan is not the exact same as Medicaid benefits, but it is comprehensive health coverage and it's at no cost to folks. No copay, no premium. And then 2 of the 3 Medicaid plans will be offering that as well. So if you're an AmeriHealth or a MedStar Family Choice member today, you will transition to that AmeriHealth or MedStar Healthy DC plan. And so you will have kind of like the same folks that you normally contact, all that kind of stuff. Individuals that are in the WellPoint Medicaid plan will transition over to a Care First plan that will be offering Healthy DC. So it is a big change. And I didn't call it earlier, there is a smaller portion of the adults that are impacted that won't be eligible for Healthy DC. They will likely qualify for something that's called a qualified health plan through the health benefits exchange. And it does come with subsidies to reduce the cost. But, I want to be real clear. We realize for folks going from Medicaid to what's QHP or qualified health plan, there are premiums and cost sharing that might not be something that's that folks can afford and could be difficult.
Okay, I didn't see another question, so I'm going to sneak another one in. you're not totally, this is in your wheelhouse, but not totally, because it's about Social Security, right? And because individuals become eligible, at least ours, you know what I'm saying, for HSCSN or whatever it is, based on their Social Security eligibility. Do you see, it may not be noticeable now, but is there anything up the road with Social Security eligibility? You know what I'm saying? That would affect us. You know what I'm saying? Up the road. And I know.
You're right, it's not entirely my wheelhouse, but
Mhm.
fortunately I asked one of my staff about this. Right now, we don't see, I mean, to my knowledge, there are no plan changes to Social Security at this point. So, and I do not have enough experience about Social Security policy to try to pretend what could come up. That's way outside my wheelhouse, Rhonda. So
yeah.
I couldn't tell you. I would be
I
helpful,
can
but
add a
right
bit to
now,
that.
we don't see changes on that front that we know of. Okay.
Yeah, I
Alright.
can add a little bit to that, and we can send you some of the training materials that we developed through DHCF that just outline like what is eligibility criteria now. I'll pop those in the chat in just a second. But we've seen just historically, we've seen like retirement age go up, you know, during my working years, that there's some of those things that we've seen over time that have happened. But again, like Melissa said, nothing very concrete on the horizon that's under consideration, but we can certainly share some of that information about what those criteria look like as of today, and no crystal balls for what's going to happen in the future.
Well,
And I
thank
do just, Rhonda, real quick,
Mhm.
want to reiterate, if you are
Mhm.
having problems with your Social Security or SSI, even though that's kind of the automatic pathway to Medicaid coverage, if
Mhm.
something's happening there, you know, it doesn't mean that you have no other pathway to Medicaid coverage. And so please reach out. Again, if you're with HSCSN, they're probably already on top of it. They can talk you through it, but I don't want, just know that I feel really confident there's likely a pathway to maintain coverage, okay, on that front. So I don't want folks to be stressed over that, but reach out if you think you're running into an issue or SSA is not responding, you can't get that appointment timely. Please reach out and let us know, and we'll do what we can.
Okay. Thank you so much, Melissa. Anna, one other question. Since it's Children's National, I'm getting the questions about us getting neuropsych evaluations and the waiting list being years still.
Yes,
Mhm.
at Children's National, within Children's
Mhm.
National, the
Mhm.
wait list is long. So our care managers in the UM team identified we have other providers outside of Children's National that are available. So we're putting our enrollees on wait list across multiple providers. Children's National over a year long. You're absolutely right.
Yeah, yes.
Yes.
Okay, okay, 2:31. So thank you both Melissa and Anna for your time today, and all of you that have participated. We would get, I think we shared going to share at least the presentation, I think was in March, and then the one that Melissa did today, that PowerPoint, I should say. If you all have any other questions, both of them have shared their information. You all know my information as well as Craig. So if you need to get to any of us so that you can get things resolved, that's what this is about. Melissa, I'll probably be contacting you with the parent, I think Catherine, that shared some of that issues with the Social Security. So I do, she's part of my Family Ties of DC program. So I will be reaching out either with her or guiding her through that process, okay? All right, we will, one of the things we didn't talk about, because it's holidays, Thanksgiving and Christmas, and they are, or whatever your holiday season is the third or the third of our meeting of the month. So we will probably have some other shift in our meeting, and it probably will just be one. So it won't be our normal third Thursday. So just be aware of that. We should be having hopefully DDS coming back about the complaint process, or at least we will have some updates concerning that at the next meeting. And I'm sure our partners, Anna and Melissa, will keep us updated if anything else occurs that we need to know. Thank you again. You all have a wonderful day.
Thank you.
Take care.
Thank you.
Thank you.
Thank you.